Sam. I'm a fourth-year student at the Uniformed Services University, and I'm making this lecture to familiarize you a little bit more with some of the most common causes of the red eye and some of the things that are very important to treat. And you can see there's a very extensive list of things that belong on the differential for a red eye. That's just to kind of show you that there's a lot more to it than simple cases of conjunctivitis. That said, we're going to be focusing our talk down a little bit more. We won't be talking about every item on this list today. Now, there's a great chart from the American Association of Family Physicians that kind of covers how the red eye should be approached, and a key differentiating symptom for us is going to be pain. If the red eye is painful, pretty much no matter what, that patient's case will warrant a referral to ophthalmology. If it's not painful, note that 3 out of the 4 items at the end of this list are all types of conjunctivitis. So we're definitely going to be spending a good amount of time with conjunctivitis today. Now, we've only got a few minutes, so let's go ahead. First of all, what is conjunctivitis? Well, it's inflammation of the conjunctiva. Generally, patients can have a red eye, discharge, crusting, and if this has only been going on for a few days or a couple weeks, it's an acute case of conjunctivitis. So the hallmark features of viral conjunctivitis are going to be itching, burning, and especially look for recent upper respiratory infection or recent cold. And it usually moves from one eye to both. OU is our abbreviation for both eyes. The most common cause is going to be adenovirus. And there's kind of a triad for this. Think about pharyngitis, fever, and children, and those are going to be your most common patients for this. But also be aware that there's a hemorrhagic conjunctivitis associated with subconjunctival, you guessed it, hemorrhage, and that is usually caused by Coxsackie and enterovirus. Usually, this is found in tropical regions. Now, viral conjunctivitis can still make the eye look awfully inflamed and uncomfortable. And one of the key physical exam findings you're going to be looking for are follicles on the inferior palpebral conjunctiva. Now, palpebral just means you're on the side of the eyelid. Bulbar would be the eye itself. So follicles on the inferior palpebral conj. And these are an inflammatory development resulting from the accumulation of neutrophils. And if you find one, you should be palpating for a tender preauricular lymph node. That's another key physical exam finding for a viral conjunctivitis. Now again, follicles tend to be on the lower lid, and they have vessels around their borders, which are in contrast to papillae. Now papillae are also sort of raised masses, but they look a little bit different. So we'll cover this again briefly. Follicles are resulting from the accumulation of neutrophils, and you see blood vessels accumulating around the borders. Now papillae come usually from allergic reactions, tend to be on the upper eyelid, and tend to have vascular tufts in the middle. So instead of seeing vessels around the border, you see them in the center. Now, treatment for viral conjunctivitis is usually supportive. It's very important for patients to avoid touching their eyes and to wash their hands just so that they can avoid spreading that virus to other patients in between their two eyes, if at all possible. Now, if a patient develops pseudomembranes, as you see in this picture here, you can peel those, and if pseudomembranes have developed, treating with a topical steroid may be appropriate for that patient. Now, there's one type of patient for whom steroids are absolutely contraindicated, and that's for a patient who has a viral conjunctivitis caused by the herpes virus. These are associated with dendrites on the cornea, and that's this sort of star-shaped pattern that lights up under fluorescein dye. Now, the herpes virus can also affect the conjunctiva, not just the cornea, and it can affect the tissues around the eyes. It's very important not to use the steroids. That can cause long-term and much more serious damage to the cornea and compromise the patient's vision permanently if that infection gets out of control. All right, moving on. Allergic conjunctivitis is going to be one of the other most common causes of conjunctivitis. It is part of a systemic reaction to a systemic allergen. So this is not something that's just occurring in the eye. And the symptoms are going to be boggy conjunctiva, hyperemia, or basically a red eye, watery or ropey discharge, and just like viral conjunctivitis, itching is also a feature of allergic conjunctivitis. So how do we treat this? Well, wait a minute. Let's take a look at the pathophysiology. Now, remember, there are allergens moving systemically throughout the patient's body, and there are mast cells and H1 receptors on vascular endothelium. And once these receptors are activated and histamine is released, mast cells degranulate. When mast cells degranulate, numerous inflammatory markers are released, which increase vascular permeability and recruit more neutrophils to sites of irritation. So, what does that mean practically? Well, it means the blood vessels get more watery, the patient's eyes get more red. Again, that's why we actually see increased redness and that conjunctivitis. Now, because we're dealing with the systemic allergen causing this reaction, we want to use a systemic medication. And to deal with the hyperemia in particular, we may actually use a vasoconstrictor. Specifically, you can actually use an alpha agonist, an alpha 1 agonist to constrict blood vessels. However, that's sort of treating the external symptoms rather than the actual cause. And if we want to address the allergic reaction more directly and kind of stop it in its tracks, we can use NSAIDs, anti-inflammatory medications. We can use H1 receptor antagonists. And even topical steroids may be employed. Now, there's a stronger form of allergic conjunctivitis called vernal or atopic conjunctivitis, usually associated with seasonal changes, and this is also associated with a thicker, more ropey discharge. You may actually see thick strands of mucus, but the most prominent feature of this illness is Horner-Trantes dots, which are white dots, pretty large and noticeable, that form around the edges of the cornea, and these are associated with eosinophilic accumulation. Now, this is treated much in the same way that regular allergic conjunctivitis is treated, but just understand that you're more likely to progress to treatment with steroids and immunomodulators, especially if corneal ulcers develop. There's another kind of conjunctivitis we need to be aware of, and that's giant papillary conjunctivitis. Remember, we talked about papillae developing on the upper eyelid. Well, this is a kind of allergic conjunctivitis that develops in association with contact lens overuse. And you can see the vascular tufts here. See that red right in the middle of the papillae in some of these papillae on the patient's blood vessel. This is best treated by having the patient stop wearing their contact lens and then treat it like you would treat another allergic conjunctivitis. Bacterial conjunctivitis is different. It's not going to be associated with so much itching, but it will be associated with purulent discharge. The most common offenders are going to be staph species, but in kids, given the connection between the eustachian tube and the nose, and the fact that the tear duct also drains out in the nose, you have a point of connection. And because of that, offenders for ear infections, otitis media, like strep pneumo, moraxella, and H. influenza are also going to be possible offenders in cases of bacterial conjunctivitis. These should be treated with antibiotic drops. Now, we also need to be especially careful for gonococcal conjunctivitis. The purulent discharge is much more severe. It has a rapid onset, and it should be treated with ceftriaxone. Sexual partners should be treated in cases of adults. Also be aware that this can present in infants. It will typically present after a chemical conjunctivitis would present within the first 2 to 3 days of pregnancy, and then kind of in that 3 to 5 day window, be on the lookout for gonococcal conjunctivitis. And do remember that if a child or a newborn develops bacterial conjunctivitis after that 5 day window, you're more likely dealing with a chlamydial conjunctivitis than a gonococcal cause. All right, there are some other causes of conjunctivitis, that is, things that would cause inflammation in the cornea in particular. Superior limbic keratoconjunctivitis we're going to look at briefly because it's got some great pathophysiology. Now, this is associated with microtrauma to the superior limbus of the cornea, and it is due to inflammation. It's associated with surgery, on the eye, especially plastic surgery. Anything that would kind of nip tuck or tighten up the eyelids will cause a little bit of increased pressure and contact between the superior part of the eyelid and the superior limbus here. And that extra friction can cause superior limbic keratoconjunctivitis. It also has increased prevalence in patients with thyroid disease. That's because thyroid disease has an increased prevalence of proptosis. So if the patient's eye is pushing out, again, you're more likely to get increased friction and microtrauma between the upper eyelid and the superior limbus on the patient's eye. Be on the lookout for subconjunctival hemorrhage. This can be just a little bit of blood or a lot, like we see in this picture to the right. In either case, whether it's little or small, this tends to resolve on its own without any extra treatment. Also be on the lookout for Stevens-Johnson's or toxic epidermal necrolysis, both of which make a patient more prone to ocular pemphigoid in the long run. These diseases are characterized particularly by pseudomembranes forming and connecting the inferior palpebral conge with the bulbar conge. This can be painful for the patient, difficult to deal with. They should absolutely be referred to an ophthalmologist for regular treatment, any patient who develops Stevens-Johnson's or TEN. Now, in the eyelids or surrounding tissue, there are a few other things that can kind of go wrong that can predispose a patient having a red eye. Ectropion tends to occur with old age, and it happens when the eyelid sort of starts to sag away from the eye, exposing more of the conjunctiva and allowing it to become irritated. Entropion is a condition that occurs when the eyelid involutes and points inward, and you can imagine that the eyelashes irritate the conjunctiva when this occurs. Now, trichiasis is a condition where eyelashes themselves start growing inward and irritating the conjunctiva, and distichiasis is a condition where eyelashes begin growing posterior to this gray line here. And with these extra lashes growing, they tend to irritate the conjunctiva and again need to be removed for the patient's comfort and safety. A floppy eyelid syndrome is a condition that tends to occur when the fibrous connective tissue in the gray line in the tarsus of the eyelid becomes floppy for whatever reason. It's suspected that it's due to the tissue becoming fatty and losing its strength, because this condition is associated with OSA and obesity. So floppy eyelid syndrome itself happens when this upper eyelid loses its elasticity and the upper lid can be pushed up, usually during sleep, again exposing the patient's eye, just like an ectropion, and allowing the eye to dry out or become irritated. Canaliculitis is usually an obstruction of the nasolacrimal duct and can lead to inflammation in the patient's eye. Dacrocystitis, on the other hand, is usually an infection of the lacrimal gland, and you can see here on MRI a normal lacrimal gland on the left and an infected lacrimal gland on the right. This needs to be treated with antibiotics, and in fact the patient often needs to be admitted to make sure that orbital cellulitis does not develop. Speaking of, let's talk briefly about the difference between preseptal cellulitis and orbital cellulitis. Preseptal cellulitis may look scary. You might see a big swollen, red-looking eyelids, but it's just infection of the tissue around the eyelids themselves. Orbital cellulitis is infection behind that, and it's associated with key features: proptosis, pain with eye movement, and restricted motility. If you see those features, the patient needs to be admitted, and you should start treatment with broad-spec antibiotics right away. Now, also be aware that tumors can cause red eye. You can have basal cell carcinomas that have a pearly appearance like this. Squamous cell carcinomas, with their typically more ulcerated appearance, can also appear on the conjunctiva, where they sort of look red and spongy like you see here. Be aware that melanoma can also occur in the eye, not just in the sclera, but also in the iris. Chalazion is a long-term or chronic kind of granulation tissue that forms usually after an acute infection affecting some of the glands that produce oil or anterior posterior to the gray line. Steyr hordeolum refers to an acute infection on the eyelid. Blepharitis and meibomitis, respectively, are irritation and infection around the eyelashes, and inflammation of the oil-producing glands that lie posterior to the gray line. Pediculosis is the medical term for crabs. These are lice that sit on the eyelashes, and acne can also cause a red eye. Other causes that we need to be aware of are keratitis. That's inflammation of the cornea itself, but it can cause the rest of the eye to become red. And why is it important for us to bring up keratitis? Because many parents are not vaccinating their children for measles, and measles the measles virus can invade the cornea and actually cause terrible ulcers. Measles are not an uncommon cause of blindness in the developing world for exactly this reason. And you also need to know that children who have measles tend to benefit from oral vitamin A. That's going to be protective of their vision in the future. A patient with anterior uveitis will also tend to have a red eye. Anterior uveitis associated with HLA-B27 disorders. And here you can see some of the flare, some extra protein in the eye. It's hard to see any actual white cells in this picture, but you can see keratitic precipitates here, accumulations of white cells sticking to the back of the cornea in this patient's inflamed eye. Carotid cavernous fistula we're going to address just briefly because the pathophysiology is excellent. Take a look at this drawing from Netter showing the internal carotid artery passing through the cavernous sinus. Now, if a fistula developed here, what would happen? Well, the pressure in the cavernous sinus would increase because of the connection with the carotid artery. Now, if pressure increased in the cavernous sinus, imagine what would happen to blood trying to drain from the eye. Well, it would simply back up. It wouldn't be able to drain anymore, which is exactly what happens. And you can see in this patient with a carotid cavernous fistula, the vessels in the conjunctiva and sclera are not draining properly, and there's a classic corkscrew appearance of the blood vessels that is only seen with carotid cavernous fistula. Other things that can cause a red eye are foreign bodies, UV or chemical burns. So make sure to check your patients for environmental exposures and evert their lids to take a look for any offending foreign bodies when they come in with red eyes. Scleritis is associated with connective tissue diseases, and also be on the lookout for hyphema. If you don't look closely at a patient's eye, you might miss it, but it's an accumulation of blood, usually associated with trauma. A patient should be referred to an ophthalmologist should you discover a hyphema. And the last thing we need to talk about is angle closure glaucoma. A patient who presents with this will have elevated pressure, they'll have pain and photophobia, and they'll often have a hazy cornea. Now, aqueous fluid drains out in the eye through the trabecular meshwork and the canal of Schlemm, and there's an angle here which, if it closes, prevents aqueous fluid from draining properly. So if a patient presents with angle closure glaucoma, we initially treat medically with things like beta blockers and carbonic anhydrase inhibitors like acetazolamide. We're trying to drop pressure in the eye and reduce production of aqueous humor by the uveal tissue. If that does not work, we can actually do a laser iridotomy to create a hole for aqueous fluid to escape and ideally lower the pressure inside of the anterior chamber. Now, if a patient presents with acute angle closure glaucoma, this is a medical emergency, it's vision threatening, they need to see an ophthalmologist right away. All right, I know that was a lightning overview, and we haven't addressed everything, but we've been able to talk about some of the most common causes of the red eye. I hope that familiarizes you a little bit, and if you have any questions about what we just talked about, I would love to hear from you. Please write to me at samuel.philbrick@usis.edu. Thank you.